Aisha Jalani from Columbia University Irving Medical Center, and I'm the director of the Women's Heart Health Initiative at the Cardiovascular Research Foundation. Thank you so much for joining us for another one of our mini med school seminars, a series of sessions that we're happy to bring to all of you at home to learn more about cardiovascular disease and how to prevent it. We believe that empowering our community with the knowledge about their own heart health is the best way to defy heart disease. Today, we will be discussing migraine headaches and how it relates to your heart health. Migraine headaches are common and can be debilitating and disruptive to the life of the person that's suffering from them. Migraines also disproportionately affect women more than they do men. I'm thrilled to introduce our two expert discussants for this program. Dr. Sarah Volbracht is an associate professor in the Division of Multispecialty Neurology at Columbia University Medical Center, where she serves as the headache program director. She completed her residency and fellowship at Montefiore Medical Center, and her clinical interests include the comprehensive treatment of patients with headache disorders. She's also written and lectured extensively on the treatments and the management of migraines and primary headache disorders. Second is Dr. Bob Sommer, an associate professor of medicine at Columbia University Medical Center. He trained in pediatrics and pediatric cardiology and started the first pediatric interventional cath lab in New York City in 1991. And has been board certified in pediatric cardiology since 1991. He then redirected his focus to treatment of adult patients with congenital heart disease, first by starting his own practice and then by joining the faculty at Columbia University in 2005. 2017 was the first year that adult congenital heart disease was actually a board certified specialty in cardiology, and so he's been boarded since then. He's also been the lead investigator in several large studies looking at the link between PFOs, or patent foramen ovales, which he'll talk to you more about, and neurological outcomes. So we're excited to have you both here. And with that, I would love to hand it over to Dr. Volbracht, who's going to talk to us about migraines from the perspective of a neurologist.
Thank you for having me today. I am Sarah Volbracht, Associate Professor of Neurology and the Headache Program Director at Columbia University Medical Center. I am excited to speak with you today about migraine to give a broad overview of it as more than just a headache. Here's my disclosures. So first, I'm going to start with a definition, and it's important to define what is a migraine. Migraine is a common disabling neurobiological disorder where headache is the hallmark symptom. It is considered a chronic disorder with episodic manifestations. And what this means is that an individual is predisposed to recurrent attacks of severe head pain and associated symptoms for a long duration of their life. And these symptoms are nausea, vomiting, or photophobia and phonophobia, which is light and sound sensitivity. It is extraordinarily common. As you can see here, this chart represents migraine prevalence in the United States, where there's an adult population has a 12% overall prevalence of migraine, and it is more common in women than in men by about 3 times. Women have a prevalence of 18% compared to 6% of men, and the peak prevalence is between ages of 25 and 55. So oftentimes at the peak times in people's life as they're building families, building their careers, and just establishing themselves in their lives. Chronic migraine, which is defined as migraines or headaches rather more than 15 days a month, at least 8 of which fulfill criteria for migraine, has a prevalence of about 1 to 4% in global studies. It is also more common in women than in men and tends to peak for both genders in the 40s. Risk factors for migraine progression have been elucidated in research, and what this means is what causes somebody to transform from having migraines every once in a while, what we call episodic migraine, to chronic migraine, which is the headaches more than 15 days a month. And there are certain modifiable and also what we call non-modifiable risk factors for prevention. Non-modifiable risk factors are things that we certainly can't change, such as our age, gender. Women are much more likely to progress than men, and socioeconomic and educational status. But there are many risk factors that are considered modifiable. And of these, we have ineffective acute treatment, persistent frequent nausea, high headache frequency, medication overuse, obesity, depression, stressful life events, and actually asthma. What's not entirely clear is if treating and addressing these risk factors will prevent progression, or if you have somebody with chronic migraine who has these risk factors, if treating them will induce a remission. However, they have been identified as important comorbidities that we have to be aware of. Migraine does progress from episodic to chronic migraine at a rate of 3% per year, but it also does remit. 26% of patients with chronic migraine remit within 2 years of onset, so there is always hope and people do get better. So patients with chronic migraine are also more likely to have other medical comorbidities compared to episodic migraine, such as depression, anxiety, chronic pain disorders, pulmonary conditions such as allergies and asthma, sinusitis and bronchitis, cardiovascular disorders such as heart disease, angina, and stroke, cardiovascular risk factors such as hypertension and elevated cholesterol, obesity, and gastric ulcers as well. And migraine also is extraordinarily disabling. It is the 7th highest cause of disability worldwide, accounting for more disability-adjusted life years than all other neurologic disorders combined. And in patients younger than 50, it is the 3rd highest cause of disability and is overall the 3rd most common disease worldwide. So it is extremely common, extremely disabling throughout the world. About a quarter of chronic migraine patients versus 3% of episodic migraine patients report very severe headache-related disability. And over a 3-month period, patients with chronic migraine are about 2 to 3 times more likely than patients with episodic migraine to report having missed work or school, household productivity, and family activities as a result of their migraine headaches. So this has an impact on all domains of a patient's life. And migraine is more than just a headache. While headache is the hallmark and oftentimes defining feature of a migraine, there are 4 distinct phases of migraine: a prodrome, which is oftentimes a few days, up to 24 to 48 hours before a migraine attack, where patients can start to experience a variety of symptoms; an aura phase, which I'm going to go into a little more depth of in a moment; the headache phase; and then the postdrome, which is the residual even after a pain resolves. Patients still don't necessarily return to their baseline for up to 48 hours after the pain has resolved of a migraine. To delve a little bit more into aura, about 30% of migraine patients have aura, so it is not the most common type of migraine that we see, but it is still remarkably common. Aura is defined as a fully reversible focal neurologic symptom. It can be visual, sensory, language, or motor in character, and it spreads gradually over about 5 minutes. And each aura symptom typically lasts less than 60 minutes, but it can be longer. Usually aura comes before the headache starts, so it oftentimes warns a patient that a migraine headache is about to begin, but not always. Sometimes it occurs during the head pain, sometimes after, and sometimes even in the absence of head pain. An aura is not hunger, fatigue, overall not feeling right before a headache, which sometimes also patients identify, and that would be considered one of the prodromal symptoms. And it's not blurry vision, which is extraordinarily common during headache. It's more of a transient and reversible visual phenomenon, such as you see in this picture. Is only one example. However, it can take many forms. And why does aura matter? Why do we put so much stock in trying to learn about the pathophysiology of aura? And ultimately, one of the things that we have learned is that migraine with aura is associated with an increased risk of ischemic stroke and major vascular events. Now, it's unknown if women are at higher risk than men and if gender plays an enormous role in influencing this risk. Most studies have been done in women out of kind of women's health studies, and so we have a lot more data on women with migraine with aura than with men or in both genders, but it is a risk factor that has been identified. And if you look, the risk factor plays the biggest role in younger populations, so women under the age of 45 to 50. So an odds ratio for stroke in women younger than 45, if they have migraine with aura, they're about twice as likely to have a stroke. If they have any migraine and smoking, 3 to 9 times more likely. If they have any migraine and are on combined oral contraception, 4 to 8 times more likely. And if they have any migraine and are on combined oral contraceptives and also are smokers, it's about 10 times more likely to have an ischemic stroke than women without these risk factors. Cardiovascular disease risk is also increased in patients who have aura. Major vascular events and myocardial infarctions are about twice as likely. Coronary revascularization and angina about 1.7 times more likely, and death due to vascular disease is a little over 2 times more likely as well in patients with aura. Keeping in mind that this slide is not to scare anybody, it's the overall risk is still remarkably low in these patients. It just shows the importance of aura as possibly an independent risk factor for cardiovascular disease that should be evaluated. And how does this affect treatment? Do we do anything different in migraine with aura patients? And the answer is no. It's very important in these patients that we identify and address cardiovascular and cerebrovascular risk factors and treat them, as we should in good medical care and practice in general. But it is important to assess patients for a history of hypertension, diabetes, dyslipidemia, family history of heart disease, smoking history, and counsel them extensively on smoking cessation and the additional risk conferred by aura history. We manage migraines with best clinical practices. Now, there is no evidence that managing migraines and lowering the frequency of migraines with prevention and acute treatment reduces the risk of cardiovascular disease, but this is best clinical practices to appropriately manage their headaches. There are no specific medications that are recommended for cardiovascular disease prevention in patients with aura at this point in time. And one thing that we don't yet know, is the aura itself a risk factor, or is it a marker for something else that is a risk factor for the cardiovascular disease? And hopefully we'll learn more over the years as more research is done. And I'm going to briefly talk about how we treat migraine without going into a lot of detail, as this is beyond the scope of what we talk about. But all patients with migraine should be given acute treatment, and preventative treatment, which reduces the frequency of migraine, is largely based on frequency and disability. Typically, the rule of thumb is more than one headache a week of migraine, or rather more than one headache a week is when we should start to talk about migraine preventative therapy. Acute migraine management, our goal is we want to quickly and consistently restore patient to normal function without pain recurrence. The typical primary endpoint that we look at in clinical trials for acute migraine management is 2-hour pain freedom. So when we evaluate patient response, that's our gold standard of what we look for. Ideally, patients do get benefit earlier, but a 2-hour pain freedom and freedom from most bothersome symptom identified as nausea, light or sound sensitivity are important markers when assessing treatment. We have to recognize that suboptimal acute treatment is a risk factor for migraine progression. We have to address nausea and make sure that we're addressing a migraine-specific medication, particularly in patients who have not responded to anti-inflammatories such as NSAIDs or combination analgesics. To optimize abortive therapy, we want to make sure that we're using the adequate dose and the appropriate formulation. For example, if somebody has significant nausea or vomiting, an oral formulation might not be appropriate, and we could use one of the various intranasal formulations or other administrations. We want to counsel patients to use early and at the mild stage of headache, monitor response closely and adjust therapy accordingly, such as using combinations of treatments, adding anti-nausea medications, and preventing medication overuse by limiting use ideally to no more than 2 or so days in a week to avoid this, what we consider rebound headache. Preventative therapy is extremely important, again, based on frequency of headache. When patients are having 1 or more headache days a month, it should be discussed. And the goal of this overall is not to take away the headaches completely. Unfortunately, we do not have a cure, but the goal is to reduce headache-related disability, frequency, duration, and intensity by at least 50%. We want to improve responsiveness to abortive medications and reduce abortive medication requirements. The general principles is we want to consider other medical and psychiatric conditions and selecting a preventative medications of one of the many classes that we use. For example, if somebody has difficulty sleeping and insomnia, we might want to use a medication that can help with sleep as one of the potential side effects, as just a general example. It's not always that easy, but there are options that we have to take in mind the whole picture of patients. Tips to improve adherence is we want to start low and titrate slowly to a therapeutic dose. Shared decision-making with our patients is extremely important so that we have an understanding of why we're picking the treatments that we pick and what our goals of therapy are. We have to have realistic expectations of what type of benefit we expect to see and when, and the recognition that things do not work right away. There has to be some diligence and follow-up so that we can make adjustments if there's tolerability concerns and give an adequate therapeutic trial, which is typically a couple of months on preventative medications. And while this might sound very easy and straightforward, it is not, and that migraine is undertreated overall. And it seems that extraordinarily very few patients are given preventative medications who should be on them. Large surveys have shown that about close to 40% of patients who have migraine should be considered or offered preventative therapy, but only about 13% of patients are on it. And patients with chronic migraine fare even worse. Less than 5% of patients in large studies are able to successfully traverse all of the barriers to care, to receiving appropriate acute and preventative treatment, from consultation to obtaining an accurate diagnosis and being given adequate acute and preventative treatments. And in patients with episodic migraine, only about a quarter of patients receive migraine-specific acute medications. So that would indicate we have multiple areas for improvement in migraine treatment. There are several medications that we use that have really great level A evidence and are effective for migraine preventative. There has been an explosion of new treatments in the last several years that are migraine specific and target what we have learned about with pathophysiology of migraine, but there is still room for improvement. Traditional adherence to some of the more traditional oral preventative medications has been extraordinarily low in studies, and it seems that after about a year, only about 13 to 16% of chronic migraine patients remain adherent to oral migraine medications, and 35 to 56% of patients with episodic migraine remain adherent at 12 months. And if you look at this curve in this graph on the left of my slides, you can see that that drop off is the steepest earlier in therapy after about 60 days or so. And this might indicate that perhaps side effects and tolerability has a large contribution to this decrease in adherence. We also have to wonder, is our measure of success enough? As I mentioned in the talk about preventatives, 50% response rate and a 50% reduction in symptoms is considered our gold standard of migraine benefit. Is this a good enough response for our patients? And I would argue no, that we should try and do better. And even with abortive treatments, the acute migraine medications, almost all patients report at least one unmet treatment need, whether it be mode of administration, speed of onset, tolerability. There's still a lot of room to improve. And like I said, there have been several treatments recently that have come out that with the goal of addressing this, but we still have work to do, and there's a lot of exciting things on the horizon as well. So just to wrap up, I just want to remind everyone that migraine is a common, disabling neurobiological disorder. Migraine history, particularly aura, should be a part of a patient's cardiovascular and cerebrovascular assessment. Migraine patients should be carefully evaluated for vascular risk factors and managed appropriately. There are several effective acute and preventative medications and treatments available, including new disease-specific targets, but there remains a need for additional therapies and treatment targets moving forward. Thank you for your time today.
That was amazing. Even again, cardiologists, we know that migraine with aura is a cardiovascular risk factor. And I think that we do an okay job, especially in preventative cardiology, asking about that as a cardiovascular risk factor. But I learned so much from your talk. I think that there's so much that's unknown about why that particular migraine with aura is something that increases cardiovascular risk in the future. I think it's so interesting.
It's fascinating. I mean, there's so much that they're learning about what's involved, and there's platelet probably activity.
Yeah, I think the stages of life are really helpful. But I think one of the really interesting things, at least to me as a cardiologist, are the fact that these risk factors that we see in so many patients, regardless of whether they have migraines, can also be linked to the platelets. So for example, there are patients who have abnormal platelet function and can make more clots than other people. There are patients who smoke. Smoking increases platelet activity and increases the risk of making clots, as do the birth control pills and the hormone replacement therapies, which contain estrogen. So, there may be a very common link here to why patients with aura have these increased risks of cardiovascular disease. Some of it may be related directly to the PFO, for example, stroke, as we talked about before. But others of them may be that these patients may simply have abnormally high platelet function and may be at risk for making clots throughout their body, regardless of whether or not they have a hole. I'm a cardiologist, but somehow in my career, I've managed to get all tangled up with migraine headaches. And that's due to the relationship of migraines to this very common hole in the heart called a PFO. We'll come back to that in 1 second, and I'll explain exactly what the PFO is and how that works. Migraines are so interesting because they're so poorly understood, despite all the research and all the really smart people that are working on this. we really don't understand them very well. And one theory about migraines is that they're like a symptom, like a fever. So you could have many diseases which cause fever, but you really need to treat what is out of whack in the patient's system, what the underlying problem is before you get rid of the fever. And in migraines, there's clearly going to be a number of mechanisms, but we really just don't know them all. But one of the really interesting ones that we are learning about a lot right now has an interesting story. It starts back in about 2000, where a group of Swiss doctors were closing these common holes that I mentioned, the PFO, for patients who had suffered with stroke. And what they found, curiously, was that after closing the holes, the migraines got completely better in some of the patients, or got dramatically improved after closure of the defect. And so I'm going to come back to that in a second, but what is a PFO exactly? It's an interesting structure. It's a normal part of the fetal circulation. So if you look at the two top chambers of the heart from the front of the patient, the right atrium and the left atrium are separated by a wall. And that wall, as the baby is developing in utero, forms in two pieces and kind of forms a little flap in the heart wall that can open and close. And the reason for that flap is to let blood cross from the right side of the heart to the left, which lets the blood get back to the mother to be filtered and re-oxygenated since the baby's not breathing yet. After birth, the flap shuts, and over time, the two pieces of the wall grow together and complete the wall. But in about 25% of the entire population, there's incomplete closure of the flap. And then throughout the patient's life, the flap can continue to open and close and continue to allow the blood to cross from the right to the left. And when this occurs, we call it a patent foramen ovale, or PFO. So that's what we're talking about, a small flap that's present in about a quarter of the population. And this is what it looks like on an echo. You can see the little flap bouncing up and down there under the arrow. So that's what a PFO looks like on an echo picture. Now, how is this related to migraines? Well, the truth is that nobody really knows. But the idea that if you can close the hole and the headaches go away, there must be some unknown triggering substance that belong on the right side of the heart, but don't belong on the left side, which are able to cross through the flap and get to the left side of the heart and then reach the brain in very high levels, perhaps triggering the migraine symptoms. And so this is at least the working theory about how PFOs and migraines can be related. So when this was published now 20 years ago, it set off a flurry of early research in the migraine PFO space. People were set out on proving that closing the PFO was a good therapy for migraines. And ultimately, that research was super discouraging. It proved only two things: that closing the PFO only helped some of the patients, and that we had no idea how to pick out the patients who it would help. And so a lot of the idea behind closing PFOs to treat migraines has gone by the wayside for about the last 15 or 20 years. But ultimately, in 2011, here at Columbia University, we found that there was a connection between migraines and PFOs that was linked to the platelets in the blood. The platelets are the part of the blood that start the clots from forming. I think this will be an interesting discussion to have after the talk, because this may well be an important factor in why patients with aura have the cardiovascular risk factors with abnormal platelet function potentially. It also turns out that patients with aura have many more PFOs than patients without aura. So it turned out that in 2011, when we gave patients with PFO who had migraines a medicine to inhibit the platelets, the migraines simply went away in about 2/3 of the patients. And it predicted that with nearly a perfect correlation, which patients would ultimately respond to the PFO closure. And the question we had was why? And so if you give patients antiplatelet medicines, perhaps the triggering substances which are causing the migraines would be reduced on the right side of the heart if the platelets aren't as actively producing their chemicals and their small clots. If you reduce the amount on the right side, the amount that would reach the left side and then the brain would also be reduced. And the idea that the medicine could reduce the amount that's reaching the brain would correlate exactly with the idea of putting in a little patch to close the hole, because then even with normal amounts of these triggering substances, the flap could no longer open and nothing would get across to reach the brain. And so it turned out that the medication response predicted exactly what the response to the closure would be. And so ultimately, we found this relationship, which not only gave us a new treatment for migraines, which was really wild and kind of way out, this blood thinner therapy, but also gave us a test to figure out which were the patients who would most likely respond to the PFO closure. And that's why I wanted to mention to you briefly this brand new national medical trial called the Gore Relief Clinical Study, which is starting at 25 hospital sites across the United States this spring, which is going to prove the link between migraine and PFO, prove that that's a real association, prove that the platelet medications can eliminate the headaches in some patients, and then ultimately prove that the patients who respond to the medicines also respond to the PFO closure. So in a very short time after you've viewed this program, there should be access to the Gore Relief Clinical Study site online. You'll be able to get information there if you are interested in finding out more. The study is kind of complicated, but I thought some people might be interested in hearing how we do some of these research projects. So we would pick participants with migraines who meet the study entrance criteria. We would then do an ultrasound test to make sure they had a PFO or prove that they didn't. And then in the PFO patients only, we would figure out what their baseline headache frequency is, how many headaches they have each month, and then give them either the platelet medication or a placebo medicine, a sugar pill, to show ultimately that the platelet medications work while the placebo medicines don't. The patients will not know what they're taking. Then we will check the patients who have had a good response to the medication, bring them to the cath lab for the PFO closure procedure, and under heavy sedation, some of the patients would get the PFO closed, and some would have what's called a sham procedure, where we would put in all the tubes but not close the PFO, and they would not know whether they got the hole closed or not when they woke up from the sedation. And that's one way that we can help to eliminate what's called the placebo effect, where people might feel that they've benefited from a procedure. In this case, they wouldn't know whether they actually had the procedure or not. Then we would stop the platelet medication and compare how their migraines are doing at the end of the trial compared to the beginning. And that's how we're going to prove that this therapy works and prove the relationship between the holes and the migraines. So that's all I have to say specifically about this interesting relationship between a hole in the heart and a headaches. And since the topic today really is the migraine linked to cardiovascular disease, we thought that this would be a very interesting discussion to have in relationship to the overall impact of migraines on heart health?
Absolutely. I mean, it sounds like there's two different things, right? So on one hand, Dr. Volbrock talked to us about how migraines with aura predispose women in particular, but predispose patients to cardiovascular disease in the future. That could be atherosclerotic disease, vascular disease, the typical neurological diseases that we think about when we think about neurology and cardiology meeting together, right? But you're talking about migraines, which, I mean, it's just so fascinating to me that somehow a small fetal, normality that persists in 25% of the population can lead to something that's so debilitating for a lot of our patients, and then be closed with something as simple as a procedure or one of these medications. Now, you talked about antiplatelet therapy, Dr. Summer. Can you, for the lay people who are watching, what are some of these medications? What are they used for typically?
So, the reason we found this link between the migraines and the PFO, first of all, it was completely an accident, like a lot of, discoveries. We were treating patients who had strokes related to PFO. So that's a really, it's not so common, but it's one of the more common ways we find out that somebody has a PFO. And in those patients, a blood clot, which normally can be on the right side of the heart with all the other substances that I was talking about. Normally those all get filtered out by the lungs as the blood passes through the lungs. But if that blood passes through the PFO, bypassing the lungs, a clot can go with it. And from the left side of the heart, it can reach the brain. So one of the ways that we've treated these patients for decades is to give them blood thinning medicines like these antiplatelet drugs like Plavix and Effiant and Brilinta are just three of them in this class. But we've been giving medications like that to reduce the risk of making clots for a long time. And initially we gave them to patients to prevent stroke, and they came back 6 months later and said, it's really weird, but since you put me on that medicine, I don't have any more migraines. And that's sort of how this all came to be.
It sounds like, so these medications always, if you're using them for migraines by itself, these medications always have side effects because they are blood thinners. And so once you can weed out the patients who actually respond to the drug, then you can close it definitively and take them off of the medication that could have long-term.
And I'll defer to Dr. Volbrock on this, but I can tell you that one of the most highest priorities for these chronic and high frequency episodic migraineurs is to get off medicine.
Yeah, I would agree, absolutely. There's no evidence that antiplatelet medications as a whole are effective for migraine prevention. And we're looking at kind of whole populations of patients with migraine, of which we have about 40 million people in the US who have migraines. So antiplatelet therapy is not recommended as a traditional migraine preventative therapy. So there's not evidence in that. However, what Dr. Summers is suggesting and what's reasonable is there a subset of patients who have a PFO where the antiplatelet medication would help select who would respond to closure? And that's a very interesting question because the PFO migraine studies have been, as Dr. Summer mentioned, very disappointing as far as outcome. Patients don't love taking medications. Many of the traditional migraine medications in the past, which is what that graph I showed, do have high rates of side effects, poor tolerability, and adherence after a year is extremely low. If you looked at it, it was chronic migraine patients, 13 to 16% remained adherent to medications after a year. And one of the most common reasons for discontinuation given is side effects. So, if you have somebody who, is on medications that are somewhat hard to tolerate and they're still getting headaches because we don't have a cure, sometimes they might give up on it without necessarily talking to a doctor or even with talking to a doctor. We have better treatments now. We have more treatments. We have new things that are coming out that target migraine-specific medications where we try and address tolerability. Certainly, there's lots of different medications, so patients might tolerate one versus another, which is why talking to the doctor is so important about what you're experiencing. But this is an avenue to look for those patients who have a PFO and patients who have migraine, particularly aura, have higher rates of PFO than the general population. Is that right, Dr. Summers?
Right.
Yeah,
Yeah,
so
the general population is about has about the same percentage of PFOs, which is about 25%, as the patients who have migraine without aura. The patients with aura, it's about a 40% rate of having a PFO. So, you know, one of the groups that we're most interested in screening for PFO are those that do have the aura, because the yields will be higher. And I just want to, you know, emphasize again, we haven't proven any of this yet. We have treated hundreds of patients actually with PFOs with these antiplatelet medications with remarkable success, but we really need to do the clinical trials in order for us to prove that this is really a benefit. But if it is, then a quarter to 30% potentially of migraine patients may have PFOs. And if we can even treat half of those, you know, we're talking to potentially 10 to 15% of all migraineurs could potentially be, you know, dramatically better or cured, you know, by this therapy.
Right. Yeah, so, and I'll just also make a plug for, while this is not proven yet, we don't typically recommend as migraine specialists PFO closure for migraine outside of the context of a clinical trial, because we don't yet know if it's going to be beneficial. There might be a subset of patients, there might not be. We can hope that Dr. Summers' theory is proven in a well-designed, and this is a very well-designed trial, and we can hope we have positive outcomes, but time will tell, and we'll have to see what happens. But as of right now, it's not a recommended treatment for migraine itself, to keep in mind as something that I think is important to remind people as well.
Absolutely. So Dr. Wolbrocht, if you were to see one of your typical patients that's a migraine sufferer who wants to find out if they have a PFO, or, you know, is interested in participating after seeing this seminar, interested in participating in the Relief trial, how would one go about that?
So I would say, you know, previous to the trial going on, if a patient would ask about PFOs, because this has been kind of in the know for the last 20 something years, of there's grumbling about if it works or not, right? And, you know, people would ask about it. And if there's not an active trial going on, I don't have a lot of guidance for my patients other than saying, we know the association exists. We know that patients who have aura have higher rates of cardiovascular disease and stroke. We don't know exactly why, and we don't know why they have higher rates of PFO and how we address that. So we would manage it, like I said, manage their migraines, and if they have risk factors, manage their risk factors, have them stop smoking, and only recommend searching for a PFO if there was another reason to. For example, if they did have a stroke and we were needing to work it up, if they needed an echo for another reason. However, now that this clinical trial is going, if somebody is interested, I think looking at you know, the sites of enrollment, I think Dr. Summers can tell a little more about finding if there is a clinical site nearby that potentially you could get screened for the trial and find out about it in the context of a clinical trial, I think is the safest and most appropriate way to, one, contribute to helping us answer this question. And we don't want to subject patients to unnecessary procedures. And until it's proven, it's not something that we can safely do outside of a clinical trial, I think.
Absolutely. I think that's perfect. And you know, I think we talked about the procedure and doing a sham procedure and all that, and that kind of can sound scary to people who are listening and say, you're going to knock me out and not do anything, stick tubes in me and not do anything. So what is a PFO closure actually like? What happens during that procedure?
So thank you. The PFO closure itself, the procedure, is called a catheterization procedure. And what it is we're going to put two little tubes into the vein of the patient's leg. There's no cuts, there's no stitches. You go home with a Band-Aid. It kind of looks like Dracula. Right.
I describe it as a big IV. Yep.
Yeah, it looks like Dracula baby when you're done, pretty much. And then through those little holes in the vein, we're going to thread tubes up to the heart, which it's a straight path from that vein. So it's really easy. And then through one of the tubes, we're going to deliver this little umbrella device, which seals the hole. And the other tube is an imaging catheter, where we're going to be taking ultrasound pictures from inside the heart. And the whole procedure takes 20 minutes. And the whole procedure, you know, it's the safest procedure we do in the cath lab by a long shot. And everybody goes home the same day. So, you know, the sham part of this is a little unnerving for patients, But because, migraines are so different than other problems like cholesterol, let's say, right? If I have a new cholesterol medicine, I can give it to you, measure what happens to your cholesterol, and we'll know if the medicine works, right? Compared to, let's say, a different medicine. But with migraines and other types of medical problems like it, the doctors can't really measure how the patient is doing. Only the patient can tell us. And so it's really important because in some of the medical trials, as much as a third of all patients given a sugar pill report feeling better. So there's this placebo effect, which is what it's called, which is very, very powerful in the migraine population. And that's why we really need to have a way so that the patients don't know for sure whether or not they had the hole closed and can really look at their symptoms objectively.
Perfect. So Dr. Volbracht, I have to ask you, because our seminars are, or initially were designed for heart problems that particularly affect women. So why is it that migraines disproportionately affect women more than men?
I think that's something that is still not entirely elucidated yet. So clearly there's a genetic basis to migraine that's influenced in part by environment, and part of that environment is hormonal. So there has to be some degree of influence of hormonal changes and hormonal expression on the genes of migraine, some of which have been identified, many of which probably haven't been, that we see. And one of the interesting things is that before puberty, boys are actually more likely to have migraines than girls. Still, the rates are lower in the younger population, but it is more common in boys than in girls in the younger ages, the very younger ages. And then after puberty is when it starts to take off in girls, more so than boys, and reaches that prevalence of 2 to 3 times more likely, really about 3 times more likely in women than in men. So there clearly is a change with the hormonal changes in entering menarche and puberty with estrogen, especially, and we see this association in women who also have menstrual-related migraines in addition to migraines outside of their menstrual cycle, where many women do report that they have headaches that are triggered around their menstruation or even around ovulation. It's sometimes harder to piece out if periods are irregular, which is often the case, but there are some women who traditionally report a consistent relationship of their migraines to their menstrual cycle. And one of the things that we think it happens is that the decline in estrogen in preparation for menstruation is one of the things that triggers the migraine expression, the rate of decline. We know in pregnancy, women traditionally do better from their migraine perspective, particularly in the 2nd and 3rd trimester when estrogen levels are relatively high and stable. And then headaches do recur postpartum. This isn't, of course, universally true. We interestingly see a more consistent benefit in pregnancy with these high estrogen levels in women without aura than in women with aura. However, we see kind of everything, but the general theory is that women do improve in pregnancy. So that really shows a clear hormonal association with it. And then, of course, migraine does start to decline in the later edges of life. If you remember from the prevalence slide that I showed, there's that bell-shaped curve where the peak prevalence is between 25 and 55. And then rates start to decline. And in women, they start to equal kind of rates in men post-menopause. Some of that kind of fading out of migraine, is it related to menopause and the decline in hormones, or is it just related to age? And that's not entirely elucidated in the literature, and in research hasn't really panned out the exact reasons for it, but that is certainly something that we see. So I think it's multifaceted. I think we don't fully understand it, but we absolutely see it.
Yeah, and I think the general theme, I can't thank you both enough for being our expert panelists, experts on this topic, because I think even myself, I've learned so much, and I can't imagine what the typical, such a large proportion of the population of the community are suffering with migraines, and how much they've gotten out of this seminar. So I hope that we can continue to build on this topic, and that the results of your clinical trial are promising, and that people will finally have some sort of data to go by, and potentially a cure for this debilitating condition. So with that, I think we'll wrap up. I can't thank you guys enough. And hopefully we can do a follow-up after the study is done, or once we get some preliminary data on this topic. If anyone who's watching has questions, please feel free to reach out on our CRF website. We're happy to bring your questions to our experts and get back an answer for you. But otherwise, thank you so much for joining us, and we hope that you'll join us in our future seminars. Of course, you can always watch this again on our website, which is crf.org/WHHI. And all of our past seminars are there as well, and any future announcements regarding future programs will be there. So thank you again, Dr. Summer and Dr. Volbracht, and we hope to have you on one of our seminars again.
Thank you so much for
Thank you.
having us.